Welcome to Board Pearls. This is episode 5 of 5 of the Colonoscopy Practice and Quality chapter in the Endoscopic Procedures module. In this episode, we cover the serrated pathway and Lynch testing and special population colonoscopy, sessile serrated lesion biology with the WHO 2019 2 criterion, serrated polyposis syndrome definition, the Lynch reflex testing pathway with MMR immunohistochemistry and MLH1 promoter methylation, and special populations including IBD chromoendoscopy surveillance, post-transplant colonoscopy, pregnancy considerations, and ESRD. The last episode read the adverse events by their recognition cues. This one turns to the other half of why colonoscopy quality matters, because this is where missed lesions become interval cancer on the right side of the colon. The molecular route is parallel to the conventional adenoma-carcinoma sequence and worth understanding directly. Sessile serrated lesions arise from colonic crypt stem cells with BRAF-V 600E as the early mutation. CpG island methylator phenotype, called CIMP high, layers hypermethylation onto that and silences a set of tumor suppressor genes. One of the genes silenced is MLH1, and loss of MLH1 expression produces microsatellite instability. The resulting MSI-high cancer is what completes malignant progression on this pathway. The conventional pathway, the APC then KRS then TP53 cascade, drives roughly 80% of sporadic colorectal cancer. The serrated pathway drives the remaining 15 to 30%, and the lesions live in the right colon, lie flat or slightly elevated, often carry a mucus cap, and require deliberate washing to see. That biology is why sessile serrated lesion detection rate is its own quality metric separate from adenoma detection rate. The clinical leverage of the molecular pathway sits in Lynch testing, and this is one of the cleanest reflex algorithms the boards test. Universal tumor screening of every newly diagnosed colorectal cancer starts with mismatch repair immunohistochemistry. 4 proteins are stained: MLH1, PMS2, MSH2, and MSH6. The clinically common loss pattern is combined MLH1 and PMS2 loss, because PMS2 is unstable without its MLH1 partner and goes down with it. When that combined loss shows up, the question is whether the cause is sporadic CIMP pathway methylation of the MLH1 promoter or a germline MLH1 mutation, which is Lynch syndrome. BF5600E is the discriminator. Sporadic CIMP pathway cancers nearly always carry the BRAF-V 600E mutation because the same molecular program that hypermethylates MLH1 also drives BRAF activation. Lynch syndrome cancers are nearly always BRAF wild-type, so the reflex is sequential. MLH1 and PMS2 loss on immunohistochemistry triggers BRAF-V 600E testing on the tumor. A positive BRAF-V 600E result triages the patient away from germline testing because the cancer is sporadic. A negative BRAF-V 600E result then reflexes to MLH1 promoter methylation testing on the tumor because hypermethylation is the alternative sporadic mechanism that does not depend on BRAF mutation. Only when both BRAF and methylation are negative does germline sequencing for Lynch syndrome become indicated. That sequence prevents a substantial number of unnecessary germline workups in older patients with sporadic right-sided cancers. The other loss patterns route differently, and this is where mechanical application of the BRAF reflex misleads. Loss of MSH2, loss of MSH6, or isolated loss of PMS2 on tumor immunohistochemistry goes straight to germline testing without BRAF or methylation testing in between. The reason is that those losses are not explained by sporadic methylation because the sporadic CIMP pathway acts on MLH1 specifically. An isolated MSH2 loss does not become sporadic with a positive methylation test because that methylation does not exist in any clinically meaningful frequency. The reflex tree is built around what sporadic biology can and cannot explain. Aspirin chemoprevention deserves a sentence because the boards test it. A randomized trial in Lynch carriers showed that daily aspirin over a sustained period reduces colorectal cancer incidence in confirmed Lynch syndrome carriers, with the benefit emerging over a 10-year follow-up. The recommendation is to discuss aspirin chemoprevention with confirmed Lynch carriers as an adjunct to surveillance, not as a replacement for it. The full hereditary syndrome coverage lives in Chapter 36. Serrated polyposis syndrome sits at the clinical intersection of the serrated pathway and the polyposis syndromes, and the criteria were tightened in the 2019 WHO update. The current definition requires either of two conditions. First, 5 or more serrated polyps proximal to the rectum, all at least 5 millimeters, with at least 2 over 10 millimeters. Second, more than 20 serrated polyps of any size distributed throughout the colon, with at least 5 proximal to the rectum. The older third criterion, requiring serrated polyps in a first-degree relative of a known serrated polyposis patient, was removed because it lacked specificity for the syndrome itself. Two criteria, both anchored in the proximal colon, both anchored in cumulative serrated burden. The genetic basis is heterogeneous, with germline RNF43 mutations identified in a minority of cases, and the majority remaining genetically undefined. Management is annual or biennial colonoscopic surveillance with complete clearance of serrated lesions, and first-degree relatives should be considered for earlier and more frequent screening. The synthesis on the serrated pathway runs through one molecule and one phenotype. BRAF V600E sorts MLH1 loss into sporadic and hereditary. The right-sided flat mucus-capped lesion is the dominant interval cancer driver, and the lesion the quality metric SSLDR was designed to capture. The two halves connect. The endoscopist who does not detect SSLs misses the lesions that become MSI-high cancers, and the molecular tumor workup downstream is the safety net that catches the genetics when prevention fails. Special populations modify all 4 phases of colonoscopy, and the unifying principle is that the underlying physiology determines which standard step has to be adjusted. The preparation changes when the kidneys cannot tolerate phosphate or when the patient is on dialysis. The sedation choice changes when the liver cannot clear morphine or when the fetus is exposed to maternal benzodiazepines. The therapeutic threshold changes when the patient is on dual antiplatelet therapy or has rectal varices. The surveillance interval and the imaging modality change when the patient has IBD or a transplanted organ. Pregnancy is the population where elective colonoscopy is deferred whenever possible. The procedure exposes the fetus to maternal sedation, to abdominal pressure during scope manipulation, and to the small radiation dose of any fluoroscopy used. When colonoscopy is necessary, the indication has to clear a higher bar. Acute lower GI bleeding with hemodynamic compromise, suspected obstruction, and severe IBD flare requiring tissue diagnosis are the standard urgent indications. The second trimester is the preferred window because organogenesis is complete and the gravid uterus has not yet reached the size that compromises maternal positioning or venous return. Sedation considerations follow from fetal exposure. Benzodiazepines, particularly midazolam, are avoided in the first trimester because of theoretical teratogenicity concerns. Propofol with anesthesia involvement is the preferred deep sedation route when monitored sedation is needed. The patient is positioned in left lateral decubitus rather than supine because the gravid uterus compresses the inferior vena cava in the supine position and reduces venous return. The broader framework of GI procedures in pregnancy lives in Chapter 35. Cirrhosis modifies colonoscopy through 3 intersecting mechanisms. Variceal precautions come first. Patients with portal hypertension may have rectal varices that bleed during instrumentation, and any therapeutic intervention at the rectum warrants careful inspection before resection. Coagulopathy in cirrhosis is rebalanced rather than uniformly anticoagulated, which means that INR and platelet count overestimate bleeding risk in this population. Platelet transfusion targets and fresh frozen plasma thresholds for high-risk procedures follow the cirrhosis-specific framework, not population norms. The third mechanism is sedation. Fentanyl is preferred over morphine because morphine has active metabolites that accumulate in encephalopathy. Shorter-acting benzodiazepines are preferred over longer-acting agents, and propofol with anesthesia involvement is reasonable for monitored deep sedation. The intent is to avoid the encephalopathy precipitation that long sedative half-lives produce in cirrhotic livers. End-stage renal disease and chronic kidney disease modify both preparation and procedural management. Sodium phosphate preparations produce acute phosphate nephropathy and are contraindicated in patients with chronic kidney disease, in patients on diuretics or ACE inhibitors, in patients with hypertension, and in elderly patients. PEG electrolyte solution is the standard alternative because it is isoosmotic and not absorbed across the colic mucosa in any clinically meaningful quantity. Magnesium-based preparations, including magnesium citrate and sodium picosulfate combinations, require caution in advanced CKD because magnesium is renally cleared and accumulates. Patients on hemodialysis warrant peridialytic timing of the procedure. The colonoscopy is scheduled ideally on the morning after dialysis so that any electrolyte shifts produced during preparation can be corrected at the next session if needed. Anticoagulation in ESRD adds a layer because direct oral anticoagulant clearance is altered. Apixaban is the most renally tolerated DOAC. Rivaroxaban and edoxaban have reduced clearance in advanced CKD and are generally avoided. Warfarin remains usable in ESRD with the usual reversal considerations modified by mechanical valve status or recent thrombotic event. Post-transplant colonoscopy is its own consideration because the immunosuppressed patient carries elevated infectious and neoplastic risk and modifies both screening intent and procedural conduct. Solid organ transplant recipients on chronic immunosuppression have an elevated risk of post-transplant lymphoproliferative disease and skin cancers. They also carry a modestly elevated risk of colorectal cancer. The screening principle is to stay on schedule rather than to defer. The procedure itself proceeds along standard lines once immunosuppression is acknowledged. The two operational adjustments are antibiotic considerations in selected high-risk patients and a low threshold for biopsying any unusual mucosal finding. Cytomegalovirus colitis, fungal lesions, and atypical lymphoproliferative deposits, all present in this population in ways the immunocompetent algorithm does not anticipate. IBD surveillance is the population where the colonoscopy itself is structured differently. The indication is dysplasia surveillance starting 8 years after disease onset for patients with extensive or left-sided colitis. Surveillance starts immediately at diagnosis of primary sclerosing cholangitis because the PSC-IBD combination carries the highest dysplasia risk in IBD. The visual task is different from screening because the dysplastic lesion in chronic colitis is often flat and embedded in inflamed or atrophic mucosa rather than appearing as a discrete polyp on normal background. The modality choice follows from that. Dye spray chromoendoscopy with methylene blue or indigo carmine, or virtual chromoendoscopy with narrow-band imaging on a high-definition platform with targeted biopsies of any visible lesion plus interval surveillance biopsies is the contemporary standard. The historical 4-quadrant random biopsy protocol every 10 centimeters has been deprioritized in favor of the targeted approach because random biopsies have low yield and modern imaging makes most dysplasia visible. The IBD dysplasia framework lives in Chapter 14. Antithrombotic management is the cross-cutting decision that touches every special population, and the colonoscopy-specific point is that procedure bleeding risk and patient thromboembolic risk are graded against each other. Diagnostic colonoscopy with cold biopsy is a low bleeding risk procedure that allows continuation of aspirin and most antithrombotics. Polypectomy of larger polyps, ampulectomy, EMR, ESD, and PEG placement are high bleeding risk procedures that require holding antiplatelet or anticoagulant agents on the standard schedule with bridging in selected high thromboembolic risk patients. The vignette the boards favor is the patient on dual antiplatelet therapy after a recent coronary stent who needs polypectomy. The temptation is to proceed and accept the bleeding risk because the lesion is concerning. The right answer is to defer the elective polypectomy until DAPT can be safely de-escalated, because polypectomy on full DAPT carries a delayed bleeding risk that is not justifiable when the procedure is elective. The exception is an emergent indication, where bleeding source identification requires diagnostic colonoscopy, and the antithrombotic management is managed alongside, not before, the procedure. The full periprocedural framework lives in Chapter 28. The synthesis pulls the two sections together. The serrated pathway is read by molecular reflex. MLH1 and PMS2 loss triggers BRAF, then methylation, then germline, with the other MMR losses going straight to germline because sporadic biology cannot explain them. The serrated polyposis criteria are now two, both anchored in the proximal colon, and the special populations are read by physiology. The kidneys forbid phosphate, the liver forbids morphine, the fetus forbids first trimester benzodiazepines, the DAPT forbids elective polypectomy. The IBD colon demands chromoendoscopy. None of these is memorized as a list. Each is the standard algorithm bent by one mechanism that the patient brings into the room. The next chapter is the GI emergencies chapter, and it lives in the same procedural neighborhood, but compresses the time axis to hours. Massive upper GI bleeding gets restrictive transfusion targets and resuscitation that precedes endoscopy. Acute lower GI bleeding gets risk-stratified workup that decides whether colonoscopy, or CT angiography, comes first. Acute mesenteric ischemia is recognized by lactate out of proportion to exam. Foreign body impaction is read by the timing and the object. Caustic ingestion is graded on the Zargar scale. Esophageal perforation and Boerhaave are caught on chest court. Acute colonic pseudo-obstruction is the dilated cecum that defines the Ogilvie syndrome. The organizing question across all of those is what you do in the first hour, the first day, and the first week of an acute GI presentation. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 5 of 5 of chapter 30, and I'll see you in the next one.